अभी भी आ रहा है क्या?
No, no, now it's not coming.
The session is live now.
Good evening, everyone. Good evening, everyone. Welcome to the seventh episode of Corneal Surgery Learning Course by Delhi Ophthalmological Society. And so far, we have covered PKP, we have covered ocular surface MMG, we have covered little few steps of DALK and DMEC. So today we have an excellent speaker with us and who has trained a lot of corneal surgeon in lamellar keratoplasties, especially DALK. You must have used such instrument while doing DLK or practicing DLK. So Rajesh Fogla sir is currently the director of Cornea Clinic and senior consultant Apollo Hospital, Hyderabad. He is the visiting professor to University of Moindad, Argentina, and Al Bahar Hospital, Kuwait, and Lanka Hospital, Sri Lanka. He is the founding member and past president of Cornea Society of India. And Cornea Society, the growth of society is largely because of Sir and his team. Congratulations for that. He is actively involved in instruction courses, largely on corneal procedures in various international conferences. He has numerous publications to his name, and some of them are in very reputed journals like American Journal of Ophthalmology, and Journal of Cataract and Refractive Surgery (JCRS), as well as JAMA. He has received many awards and notably achievement awards by American Academy of Ophthalmology, APAO meetings, gold medal for IRSI, and SICSSO, SITRAC, Orison Awards at numerous meetings in India. Most importantly, what I like about Sir is he's a very good trainer and teacher. That's why we requested him to take this lecture because we have covered the PKP, and I think this is the right time for our participant to learn DALK from Sir. So, welcome, Sir. And along with Sir, we have included an expert group, and that may not appear you very senior, but they are all excellent surgeons and they will add definitely to the discussion today. Dr. Bharat, Dr. Mugundan, and Dr. And few of our panelists they will be joining soon. Dr. Susank, yes, he has joined. So Dr. Susank, Prabhat, and Mugundan are going to carry forward the discussion part. With this, I'll like to invite Rajesh Pogla sir to share his PPT and start the lecture. Thank you, sir.
Thank you, Praful, for inviting me, and it's a pleasure being part of this webinar session. I'll share my slides. Just one sec. Mhm. Okay, so I'll be talking about how to perform a DALK surgery successfully, the clinical tips and tricks, no financial disclosures. Just trying to minimize that screen on the sides, which if you can do it from your side, maybe, yeah. Anyway, deep anterior lamellar keratoplasty refers to a surgical technique where 85 to 90% of the host stroma is replaced with healthy donor tissue. And the advantage over penetrating keratoplasty is that as the host endothelium is retained, you don't have a risk of, just one second, what's happening? Yeah, is my screen visible now or?
Your screen is not visible.
Not yet, sir.
Okay, I think I did something. Let me go back and reshare because I think. Okay, it's visible now. Is it visible now?
Yes, sir. Yes,
Yes,
sir.
yes.
Yeah, so as I was talking about the advantages, the biggest advantage is there is no risk of endothelial rejection as you preserve the host endothelium. And because of this, you need to use steroids for a shorter duration, and you can reduce the risk of secondary glaucoma and cataract development as you see with the use of long-term steroids. The other advantage is you perform the surgery in a closed chamber. So unlike a penetrating keratoplasty where the globe is open, the risk of intraoperative complication is also lower. And because you don't have the risk of endothelial rejection, you do larger diameter graft much more easily. And getting a tissue from the eye bank is also easier because you're not dependent on good endothelial cell counts for the surgery. Now, indications, any corneal condition where the endothelium is healthy is amenable to a DALK surgery. The common clinical indications are the ectatic disorders, keratoconus, post-LASIK ectasia, pellucid marginal degeneration, keratoglobus, sometimes following corneal scars, following some dystrophies, stromal dystrophies, where the endothelium is healthy. You combine it with ocular surface reconstruction. And in rare instances with infections not responding to conventional medical therapy, DALK has been reported to be successful. There are two main techniques of doing DALK. One is the manual layer by layer near decimus dissection, usually the Malbrun's peeling technique, or you can use lamellar dissectors with the Mellis technique. And if you have intraoperative OCT, quite helpful because you can see the amount of residual stroma that's left behind and decide if you need to go deeper or not. The other popular technique is also referred to as the big bubble technique, is the stromal injection of air that results in a plane of separation in the deep stroma between the predecimus layer and the corneal stroma. Earlier, we thought that this was between the decimus and the stroma. And this plane of separation can also be created with the use of viscoelastic when it is referred to as the viscobubble. Now, in the pre-op investigations, besides slit lamp biomicroscopy, where you look at a detailed of the evaluation of the pathology, both in the horizontal, vertical extent and the depth of involvement, I think for me, I need the regional pachymetry, which I can get from my tomography or from my anterior segment OCT. This gives me the corneal thickness, the regional corneal thickness, and based on which I can decide what size, what diameter of trephine I'm going to use so that I can encompass the entire pathology. The corneal OCT gives me a cross-section view where I can see if the pathology is involving the decimus membrane or the predecimus layer or remaining superficial. Besides that, you can do specular microscopy if possible to look at the health of the endothelium, but we often use pachymetry as the surrogate marker. So if you have somebody with normal pachymetry, you assume that the endothelium is healthy. In terms of trephination, we would like to do a partial thickness trephination. So you can use the Hesburgh-Barron suction trephine, where each quarter turn of the trephine cuts down a depth of 60 microns. You can have these preset depth guarded trephines, which have blades of 300, 350 microns. So you just like a handheld, you can rotate and it will cut down only to that depth. You can also use the femtosecond laser, which gives you shaped incision. And the other thing is to use a diamond knife, especially in very large diameter trephination where the suction trephine is not available. So you can mark with a 10, 10.5, 11 and use a diamond knife set to 200, 250 microns depth and do your partial thickness groove all around. Now in the big bubble technique, which was described by Mohammad Anwar and Kleis Teichmann back in 2002, use a 27 or 30 gauge needle, bevel down and go at 80 to 90% depth and inject air into the deep stroma. And this creates this big bubble, which starts in the center, expands outwards, and has a dense, frothy white margin. In 2013, Harminder Dua showed us that you can peel off the decimus membrane from a donor cornea and you can still create the big bubble. So he described the presence of a layer described as the Dua's layer or the predecimus layer, where there is an additional layer in the deep stroma. So when you inject air or viscoelastic, it creates a plane of separation between this layer and the deep stroma. Now, there are three kind of reactions that can happen. Typical one is a type 1 bubble, which starts in the center, has a white frothy margin, expands outward concentrically with a diameter of 8.5 millimeter. Here, the separation is between the stroma and the predestinous layer, as I mentioned earlier. There's another separation that happens. If you see in this video, the bubble has started, but it has it has a clear margin. It's not like a white frothy margin, and it can expand all the way up to the limbus. So this is when the air goes between the predestinous layer and the descemes membrane. So this is a type 2 bubble. And at times you will get a mix of two. That means it starts off as a type 1 and then breaks into a type 2 bubble. So this is called the type 3 or the mixed bubble. If you want to do a big bubble dark, it seems logical that that the predestinous layer should be normal. So if you have very advanced keratoconus where that layer is already stretched, if you have scars involving the predestinous layer, or you have dystrophies like macular dystrophy where you get deposits in the predestinous layer making it brittle, in all these scenarios, if you inject air, you're likely to get an abnormal response to the air injection. So instead of creating a plane of separation, you may get either a rupture, or you may get a type 2 bubble where the air doesn't stay between the stroma and the predestinous layer, but goes between the predestinous layer and the descemes, creating a type 2 bubble. So if you are starting out, I think in the case selection, any case where on cross section you can see scars involving the descemes membrane, you should not attempt a big bubble dark. Now, when you use a needle, the fear of perforating, often you keep the needle superficial and you end up creating a lot of emphysema. And then subsequently, when you try to go deeper, because the tip is very sharp and with the movement of your hand, the tip can easily perforate. So the success rate using a needle can range between about 65 to 69%. So instead of that, what most surgeons recommend now is using one of these air injection cannula, which have a bottom port and usually a relatively blunt tip, unlike a needle, which is very sharp and not very forgiving. So when you inject air, you feel an initial resistance, then a sudden giveaway sensation as the bubble forms. And as you keep enlarging, you again start feeling the resistance. If you don't stop at that point of time and continue enlarging the bubble, it can spontaneously rupture. And why does it happen? It is because the aqueous provides the counter resistance. So as the bubble is expanding, the aqueous is pressing on the bubble, so you get increase in the intraocular pressure. And to overcome that pressure, the intra-bubble pressure also increases as it's expand. So at some point of time, it goes beyond the bursting pressure and it ruptures. So what we described was the sequential air injection. That means you inject air to initiate the bubble. Once the bubble forms, you do a paracentesis to lower the intraocular pressure. So basically, you are reducing the counter pressure, and then you inject air to enlarge the bubble. Now what happens is the intra-bubble pressure is not as high as before. So you can safely expand the bubble without minimizing the risk of a spontaneous rupture. To identify whether the bubble is there or not, you can inject a small bubble in the anterior chamber after you've done the paracentesis. And if in the presence of a bubble, the small bubble will remain in the periphery. The other thing that we find is that if you have, sometimes the whole cornea may become emphysematous, and then you can't really figure out because there is no place to visualize the small bubble. So here, what you can do is you can do a paracentesis, release aqueous. If there is a big bubble present, you will find that the central part of the cornea will remain firm to touch, whereas the peripheral cornea will be soft. And if the bubble is not there, both the center and periphery would be soft. If you have intraopacity, you can directly visualize the big bubble. So how do you get a successful big bubble? You need to get your cannula deep enough in the corneal stroma. So how do you do that? One is the manual feel. When you are introducing the blunt cannula into the deep stroma, there is a resistance. If you are fairly superficial, the resistance will be greater. But if you are at the deeper plane, you will find that to advance the cannula, you don't need too much of pressure. So that's the ease of resistance is one way of figuring out whether your cannula is at the right plane or not. But if you're using a needle, you can't use this kind of difference in resistance because the needle tip is very sharp. If you keep your pupil dilated, as you will see in the next video, against the red reflex, as you're introducing the cannula forward into the cornea, you will find wrinkling at the tip of the cannula. So that also tells you that your cannula is deep enough. You can, if you have intraopacity, you can make the track and you can look at the track on the intraopacity and see whether the track is at the desired depth or it's superficial. You can use a pachymetry knife to make an initial cut going up to 90-95% of your measured pachymetry thickness. That way you have a cut that goes very deep and you can initiate your tunnel for the cannula at that depth. Newer femtosecond lasers have this dedicated software which allows you to create a track using the femtosecond laser into which you can introduce the cannula, and that can allow a successful big bubble. So once you get the bubble, you have to deflate the bubble. So you put a little bit of viscoelastic on the surface, and then you can make the eye soft and then go with a sharp knife and deflate it. As the air leaks out, because the viscoelastic is providing the counter resistance, the air does not escape quickly. It takes time, and that makes it safer. If you don't want to use a 15-degree knife, you can even use a keratome, and so the entry can be horizontal rather than vertical. It's important to, I like to mark the entry point as well, so that if my entry point is small, I exactly know where I have entered. So you can put some ink mark on your knife. Once you have done that, you do the stromal excision. As you see in this video here, you divide it into quadrants, and then each quadrant you excise. The important part, the tip that is here, is if your bubble has not gone all the way to the periphery, before you excise, use a blunt instrument and try to, create separation of the fibers up to the trephination margin first, and then go with your scissor and excise. Because without that, if you do, you have an increased risk of perforating in the periphery, or you will leave behind a large ledge of stromal tissue, which again, you have to subsequently trim it down. Donor tissue, if you are doing it for ectatic disorders, usually the same size. And if otherwise, we just keep it 0.25 larger, unlike a PKP where you make 0.5 larger. Here, you don't need, because you're not opening the eye. So the apposition of the graft and donor is quite good. So you can punch it from the endothelial side. Sometimes I like preparing from the epithelial side, because if I use the same suction refine to prepare, the edge configuration of my graft is similar between the host and the donor. You can use gamma irradiated corneal lenticules, which we call the vision gift, from which eye banks give you. The same thing they are now giving for the CARES, or the stromal segments, called the Keranatural. So we used it for DALK, and we found that it's equally effective. It is stored at room temperature, has a shelf life of about 2 years, so you can use it whenever you want. Suturing techniques are quite similar to what you do in penetrating keratoplasty, but one tip that I would like to give is that take about maybe 70 to 80% depth bite on the donor and a deeper bite on the host side, especially if your donor tissue is a little edematous. Then what happens is, post-operatively, you find that the surface apposition is quite good. I like taking slightly longer bites than what I do for my penetrating keratoplasty as well. You can start manipulating the sutures in the first 2 to 4 weeks' time. And I like using an intraoperative keratometer to ensure that I leave behind a round reflex, which helps me minimize my astigmatism. So that's how the post-operative appearance looks. And because the endothelium is very healthy, you find a very quick recovery and the graft becomes clear very, very fast. This is a video that shows you the visco bubble technique. You can see I've introduced the cannula. I've softened the eye, put an air bubble in the anterior chamber. I'm using cohesive viscoelastic and a 25 gauge cannula. And you can see that as I inject viscoelastic, it creates the same plane of separation, and the bubble in the anterior chamber moves to the periphery. Now you can see that I'll use a sharp knife to do the brave slash, and you cut it out, the viscoelastic comes out. And then you can do the same thing. You can split the segments and excise the stroma. Here, the important part is you really need to wash out all the viscoelastic. If you're using cohesive viscoelastic, because it remains as a blob, it's easier to remove. The one word of caution is that viscoelastics can also create a pseudo bubble in the deep stroma. So if your cannula is not really in the deep stroma, but somewhere in the mid stroma, you might find that you get something like a visco bubble, but when you open it out, there are still a lot of stromal tissue left behind posteriorly. So that's why I would not recommend that you start off with a visco bubble. Maybe do the big bubble using air injection first, and once you get the hang of it, you can use visco bubble as a rescue technique. That means you have used air injection, you fail to achieve a big bubble, and before you want to give up, you can create a track and you can inject viscoelastic, which kind of gives you a similar, because it's more dense than air. Even after a failed big bubble using air injection, you can create a big bubble using the viscoelastic. This is showing you the Zima Z8 femtosecond laser. We made a mushroom cut. Then we did an anterior lamellar cut for about 200 microns. And you can see that the anterior lamellar plane is being lifted off. And then we also created a track that goes close to the Decimus membrane. And we introduce the cannula into this track. And as we inject air, you will find that this can create the big bubble. So this is a good device to have, so that in the learning curve you can take advantage of technology and you can make it easier for you to transition to big bubble dark. The post-op appearance is very good. Astigmatism is minimal because of the kind of good apposition of the host and donor, because of the customized edges. And because of the increased surface area also, the wound is stronger. And sometimes you can remove sutures slightly earlier compared to what you do with manual trephines. This is a comparative study looking at femtodalk versus manual dalk, and they found that the rates of intra-op DM perforation or conversion to PK was lower with femtodalk among trainees compared to manual dalk. So they found that in terms of the in a multi-surgeon setting, maybe some steps of DALK can be done with the femtosecond laser to minimize complications. A manual DALK can be done like if you have an abnormality involving the Decimus membrane, or you fail to achieve a big bubble despite multiple attempts at air injection. So, or you had a complication when you were doing a big bubble technique and you have not yet completed the surgery, so you need to go back and know how to dissect close to the Decimus membrane. So this is basically the original Malbrand's peeling technique, where basically you need a deep trephination, and if you create a plane deep enough, because the posterior fibers are not very tightly adherent, you can use a tooth forceps and you can gently peel off the stroma from the cornea, leaving behind a smooth bed, and you can put in your donor and suture the graft. Even Melis described the same technique. He used to put an air bubble in the anterior chamber, then create a plane of dissection, looking at the reflection of the instrument against the air bubble and go very close to the decimus, and then use the lamellar dissector to dissect across the cornea. Then put in some viscoelastic to separate the two layers, and then he would trephine from the top, wash out the viscoelastic, put in the graft, and secure with sutures. What I like to do is I do a deep trephination, like 80-85%. Then I use a lamellar dissector to debulk the cornea first, so which means about 40-50% of the corneal stroma is removed. I come to the periphery, make a small deep pocket, and this is what I designed as a stromal pocket forceps, but you can use any blunt tip one, a scissor, or you can use a spatula, and you can make this peripheral pocket along the trephination margin. And once you have done that, your left hand with the tooth forceps does the main work. So you're basically trying to do the same peeling. And the right hand with this dissector is just helping you break the fibers. I can basically use two tooth forceps and hold two different edges and just try to peel it out. But then what happens is if you have any weak spot at the apex, you can end up breaking that. Now, this is the second video of a failed multiple attempts air injection. We could not get the big bubble. So now this is again a post-crosslink cornea. So I made the small groove, now using that pocket forceps to make the pocket along the trephination margin, both anti-clockwise and clockwise. And now you see, you just use the tooth forceps. I'm holding two different edges, and then you can just peel off, and that's the end point. And you can put in your graft after that and suture. So you can see that the first one is the post-eye drops, and you can see post-op, the cornea looks very clear on the anterior segment OCT. The residual bed is quite minimal, and studies have shown that if the residual bed is less than 80 to 90 microns, your visual outcomes are quite similar to big bubble dull, especially at 1 year follow-up. So it does take a little longer for recovery, but finally, I think you can reach the same point. This is, you can see bilaterally the patient has had previous eye drops and there is scar, but we still went ahead, did a manual DALK, and the patient achieved about 6/12 vision in both eyes. Complications can happen at any step of surgery, like trephination. You can miscalculate the number of turns, you can end up perforating. So what do you do in this scenario? Well, nothing to worry. You first identify how large the break is, put in an air bubble, then you place sutures to secure the wound so the air does not leak out. And then you can either do a manual dissection, as in this case, what you see, starting at the opposite end onto the perforation, or if you're experienced enough, you can still use a air injection cannula, go into the corneal stroma slightly away from the break, and you can still inject air to create a big bubble in this scenario like you see. So you avoid the big bubble coming all the way to the margin. And then you can open up the bubble, do a dissection, and like this is after the dissection, there's a small, you can see the tear here. But you need to worry that in the sense, any of these conditions where there is a large break, the incidence of double anterior chamber is quite high in the post-operative period. So what you do is, whenever I have a perforation, I would not hesitate to make a small inferior PI via inferior vertical paracentesis. And once I put in my graft, I can do a complete airfill. Just like we learned from DSEC and DMAC that if you have an inferior PI and you do a complete airfill, you don't get a pupillary block. So the same principle is applied here. Is whenever you have a perforation, do an inferior PI and do a complete airfill, and that provides enough tamponade that you can avoid having a double anterior chamber. Now, this is a surgery that I was doing. I ended up having a rupture of the big bubble, and you can see here that that's really a big rupture going from one edge of the trephination to the other, and on the OCT you can see it's a large break. So what we did was we went ahead, we started doing manual dissection from the periphery, but we went into the plane which we had created with the big bubble. I excised all the stroma, I put in my graft. After I put in sutures, I went in to the AC, and using a reverse Sensky, I co-opted the torn edges together. I had done an inferior PI, and I did a complete airfill, and that's at the end. You can see the edges seem to be quite well opposed. And that's the same patient at follow-up. You can see at 1 month, he had about 6/12 vision. There is a faint scar at the area where we had the rupture, but the patient still did very well. And at about now 3 years follow-up, he's almost 20/20. What about if you are doing a manual DALK, don't put a full thickness graft as a donor. Always look at how much of bed you have left behind. And then your donor should be designed either 300, 350, or 400 accordingly. This patient has had a manual DALK, and the surgeon had put a full thickness graft. You can see the bed is irregular, so this is not a great surgery. I went into the bed, I managed to create the big bubble. I completed the dissection, and because the original cornea donor was perfectly fine, I just irrigated it and I put it back into position, and I completed the surgery because that was full thickness. I had done a pre-op OCD, so I had looked at it. This is a patient where patient did not have suture removal on time. So he had loose broken suture and he developed a microbial keratitis. And according to the notes, he also had a perforation, and which was treated. Finally, he presented to me with this kind of a scar. And I was contemplating, young chap, whether I could do a PK or what I should do. So I took him up, and this is for surgery. You can see that we went ahead and we thought, let's see what happens. Can we do a repeat DALK for him? And we did the trephination, and we started to figure out if we can identify the plane that we created during the first surgery. Just like a LASIK flap that can be lifted years after surgery, even post-DALK, you can identify that plane and you can, so you see that we are just trying to see if we can break and get into that plane. There was a small perforation here when I was trying to find that plane, so put an air bubble, suture it. So we did manage to find the plane. Now so the fibrosis only happens at the graft-host junction. So you have to use scissors and sometimes cut that. You can see here, that's where the perforation was, and you can see there is some, radial scarring. So that's how I do my inferior PI, do a vertical paracentesis, always a surgical PI. It's a phakic, so I don't like using a vitrector. And then I put an air bubble and remove this. And then I put in my graft secured with sutures. Now, what do you think this patient did post-op? So this was in the immediate post-op, and on the right side, you can see when at 1 month when he came back, he had a nice clear graft and vision had improved to 20/30. So I think before you jump in and do a PKP, you should always try and see, especially in young individuals where the corneal endothelium may still be viable. This is again a similar case, ulcer, perforated glue, BCL, amniotic done, was referred to me for doing a PKP because patient was not happy with the vision. Again, I went ahead, did a manual DALK. You always start from the opposite, the site of perforation. So you can see that I'm doing the same peeling technique, starting a deeper plane from the opposite end. The last bit would be the part where you have the pathology. And we did that, and then you can see that that's the glue, cyanoacrylate glue that I removed, and this is the opening, what you see here. It's a big opening. I do a inferior PI, put in my graft, and again, you can use maybe 20% SF6 if you want extended tamponade in this kind of scenario. So that's the same patient in the post-operative period, and if you see, again at 1 month, this I think is a 3 months, some sutures have been removed, and his visual acuity improved to 20/30, and surprisingly, he still had a very good cell count. Intraop OCT is a great boon to have. Just that if it was less expensive, I think more people would be using it. And manual DALK. So if you don't want to do a big bubble DALK and just want to start with a manual DALK, this nice paper published back in 2013 shows that the results of manual DALK are as good as what you do with a big bubble DALK. Common complication is that double anterior chamber. So nothing to worry. If you have a double anterior chamber, because your endothelium still has access to the aqueous, so it's getting its nutrition, so nothing happens to the endothelium. Just that you have to avoid getting a pupillary block or a Urey-Zevalier syndrome. So whenever you plan to inject air or 20% SF6, I don't like using C3FA because it stays for a much longer period of time. Remember to dilate the pupil. So even before you go and do a rebubble, first you dilate, make sure the pupil is large enough. Then you put an air bubble. And then you see the patient 2 hours later to ensure that there is a clear meniscus of fluid behind, or you pump out some of the air so the bubble is clearing the edge of the pupil. But if you do a surgical PI, then you don't really need to do that because the inferior PI prevents the occurrence of a pupillary block. What do you do if you get a type 2 bubble? Well, this comparative study where 3 groups in one, they tried opening up the stroma, exposing the decimates by opening up the type 2 bubble. The second, where they just deflated it and preserved, the stroma, they found that whenever they tried to bare the decimates, the conversion to PKP was very high, almost 75%. And they had perforations as well. And they could keep the layer intact only in one eye, that is 6.3%. And post-op also, the incidence of double anterior chamber was quite high. So whenever you get a bubble like this, what you see in this video, you will see that we are injecting air, but you can see I injected air, but I got a type, here what you see, we got a type 2 bubble with a very nice clear margin. There is no frothiness. Here it started as a type 1, then became a type 2. That's the margin of the type 2 bubble going all the way to the periphery. So what we are doing here, I'm going and doing a manual dissection. Here we have the type 1 bubble. So we opened the type 1 bubble, and now we are releasing air from the type 2. We milk out the air, and then we put in the graft. So the basic idea is don't expose the decimus membrane. If you have a type 1, expose the pre-decimus layer. This is the case of macular dystrophy. And or you just go and do a near Descemet's manual dissection. Overall outcomes of DALK. One paper from Australian registry by Dr. Koster showed inferior outcomes, and they say, no, DALK should not be done. And maybe that's something to do with the learning curve and the amount of experience of the surgeon. But here, they compared studies, which some of them are single surgeon studies. They felt that, oh, single surgeon, because they are more experienced, they have better outcomes. But the current study, which is from Moorfields Eye Hospital, it was a multi-surgeon and a large number, 357 eyes, and they found that almost 20/40 or better corrected vision can be achieved in about 77% of the eyes, and the failure was only 4%. So they had reasonably good results, which were comparable to penetrating keratoplasty, but they accepted that in the learning curve, you do have intraop DM perforation, almost as high as 45%, and requires, which can be managed by ancillary measures. And but you don't really need to convert to a penetrating keratoplasty, even if you had a perforation during the DALK surgery. So if you compare with PKP, the visual outcomes are similar. In a manual DALK, the visual recovery may be slightly slower. Astigmatism may be because we use slightly 0.25 oversize, or because the corneal contour is maintained, you may have slightly steeper corneas compared to PKP. PKP, because you have an open blow, when you put sutures, sometimes you tend to flatten the cornea a little more. The endothelial cell density better preserved after DALK because it's the host endothelium. The risk of endothelial rejection is nil. Glaucoma and cataract incidence is lower, but mind it, in keratoconic patients, myopes, you have to monitor the IOP. A lot of up to 20-25% of them can be steroid responders. So if you're using Pritfort, I think it's important that either you add anti-glaucoma medication in the post-op when the patient is not able to follow up with a doctor, or monitor the intraocular pressure and add an anti-glaucoma medication whenever there is a rise in IOP. So this is a flowchart that gives you about DALK. It tells you when to do a big bubble DALK, and if you fail to achieve a big bubble DALK, how you can go back and do a manual DALK dissection. So in conclusion, DALK should be considered as the procedure of choice for corneal diseases with healthy endothelium. Surgical techniques continue to evolve. I'm sure the panelists will give their experience, and they may have certain modified steps. I think each one, they start off with a basic technique, but as you go along, you can modify. I know of surgeons who still like to use the needle instead of the cannula because they feel that they are able to achieve a much deeper plane with the needle rather than a cannula. Some like to do a paracentesis before they inject the air. I like to do a paracentesis after. But the pre-op evaluation and surgical planning is essential. If you select your cases properly for big bubble DALK, I think the incidence of intraoperative complications will go down, and your success rate of big bubble will also become very high. And in future, I think femtosecond laser technology and the intraop OCT will definitely make the surgery much more easier to perform and improve the outcomes in future. Thank you. Thank you for your patience here.
Thank you so much, sir. As I promised my delegates in the beginning, there will be a lot of practical points. I hope you people could remember and use that in your day-to-day practice. So there are few questions, but before going to the questions, I would like to go to my panelist. What Ed sir said, what is your experience of DALK, and is any, if any technique that you do little different that may be useful to the our participant? Yes, Dr. Susank.
Thank you, Dr. Pogla. It was a great talk and nice collection of videos. I think all small steps you covered very nicely and learned a lot again from you, like before. So thanks for that. So nothing different I'm doing. Just initially I started with some manual dissections, and now also I do manual dissections when big bubble doesn't comes, because it's not always that wonderful like you were showing with different variety of cases what everyone is getting. So, but when I started using that cannula which you prepared with the opening in the below, I definitely found it useful, and thanks for that great invention. small thinking, but a great big impact it made. So thanks for that. And apart from that, I just wanted to ask the how you decide the types of sutures. Like some cases you were putting continuous and some you were putting intermittent.
See, the comparative study looking at interrupted or continuous or a mix of interrupted and continuous found that neither of the techniques gave, the best outcomes. All were quite similar. So I think you should stick to, in your experience, what works best in your hands is you should do that. And as a beginner, I think interrupted is good because you can revise your suture if they are not of the right length or the tension or whatever. And you should practice the running suture in the wet lab first to get the hang of it, because, and I always, even now when I do my running, I always make some dot marks using a Sinskey as to just to identify which will be the entry point and exit point for the continuous suture, so that when I'm suturing, I exactly know the direction where otherwise what happens is in your mind, you think you are doing a great suture, but when you look at it later on, you find that in a dominant area where your hands are good, you get nice suture, but in the other area, like for a right-handed person on between 7 o'clock and 9 o'clock, where the needle cannot go, you will find that sometimes the sutures don't look very great. So I think it's a matter of practice. And the problem with continuous suture is that if you don't apply them properly, if they become loose early in the post-op, then you are at a challenge that you have to go back and you have to again revise them or put interrupted. And if your patient is not under your follow-up surgeon will not remove a running suture. They're always scared. Whereas if it is an interrupted suture that's loose, they don't hesitate to remove it. And any patient that has loose sutures which are not addressed, sometimes it can defeat the whole purpose of surgery. They may come back with a infection or a melt or. So I think that's why in my practice also for patients whom I know who will be back with me for a follow-up, or if I know that they are going to go to a particular surgeon whom I know and follow up, maybe I will put continuous suture because that gives me the advantage of being able to adjust more easily at the end of surgery with the intra keratometer. But if they're going to go away to a place where they may or may not have, an experienced corneal surgeon, or they may go to a general ophthalmologist, I will put interrupted.
Thank you, sir. Thank you. And just one more question. What about your take on cataract surgery? I saw a few of your videos when you're doing DALK with cataract surgery.
Very
So at
rarely,
which stage?
very, very rarely. But the problem is that if the cataract is significant enough, and the patient also has a corneal pathology, in India, what happens is sometimes they are like, if I do a DALK and tell them, so if you do a DALK, when do you do a cataract surgery? You have to wait till all the sutures are out, stable refraction. But if he has a significant cataract, then he doesn't have an option. So what we do is if you're good enough, you combine the surgery, but explain to the patient the emmetropia and we always try to aim a little bit towards myopia, And in the worst possible scenario, you can always think about doing a touch-up PRK later on if the patient has any, abnormal thing. You can think about piggyback IOL because these patients have normal endothelium, so you're not worried about. So these are things that you need to discuss with your patients and do that. Rarely I've done like a young patient having a DALK and then we wait, sutures are removed and then we do a cataract surgery later with a toric IOL.
Thank you, sir.
Yes, Dr. Mugundan, any points from you?
That was a very wonderful presentation, Dr. Pogla. A very nice illustrative videos also. So sir has covered most of the points in his talk. The only thing might be as advice for beginners, I can say is like as a beginner, will be more scared of perforation. So I suggest them as like when they attempt a big bubble to go in a deeper plane, almost near Descemet's membrane, inject the bubble. So as beginners will be scared of perforation and trying to inject in the superficial or mid-stroma causes more of emphysema than achieving the big bubble. So might be as a beginner, I made those mistakes. So better to when they inject the air, they should make sure they go the adequate plane, deeper plane near to the Descemet. So either guarded refine and do a lamellar dissection and then inject, or straight away also you can by using what to say that refined with that vacuum baron vacuum strip, and you can make the adequate quarter tens and then reach the deeper plane. So for a big bubble, that is the idea I can give for the beginners. Whereas for the manual dissection, like failure to get the big bubble is not the end of the dial. So they can attempt layer by layer dissection. Sarah has shown the beautiful videos also, the groove and peel technique, and layer by layer dissection to complete the uh, lamella dissection. So that's all from my side. So most of the points Sir has already covered. My
Or-
question to Fogla sir is like, hello,
Yeah, go ahead.
Yes,
can you hear me?
yes.
So now with the people using more scleral lenses, like your indications for DALK in this people using scleral lenses.
No, in my practice, surgical intervention is always the last choice. So we get people coming in straight away saying, I need a dark because I've read somewhere it's good, but they have never tried contact lenses. So we always give them a trial with the contact lens first, because let them experience if they have never tried a contact lens. Some of them have come back and say, oh, wow, I can see very well with the contact lens. So you don't need a surgery. The use of contact lens also tells me what is the visual potential. So I see that, let's say I send him for a contact lens trial. He was, let's say, 3/60 because of advanced keratoconus, but then he improves to 6/9. So I can tell him that if you do a DALK, at least your vision will improve up to 6/9. So he has some idea of. Now, people choose to undergo surgery when they are not comfortably able to wear a contact lens. So I think a good contact lens fit is the critical factor, not the scleral contact. We see a lot of patients who have had scleral lens, but they are not fitted properly. So the patients wear the lens, and within 1 or 2 hours, because it's a very tight fit, they're not able to tolerate the lens. And even when they remove the lens, sometimes they have blurring of vision that takes a long time to go away. So I think scleral lens fitting is something that definitely is optometrists, and because in a routine clinic I fit rose scale lenses, but scleral lenses I have a set, but I don't have the time to fit one, because unlike the regular RGB lens which you can fit very fast, a scleral lens is a time consuming thing, because you need to fit the lens, then you have the patient to wait, you come back, you reassess, do an OCT, look at how it lands on the sclera. So that's where an experienced contact lens fitting person or an optometrist comes into the picture, who plays a vital role. But you have patients who are in an environment, they feel that dust, or they have some history of allergy because of which they cannot wear a contact lens comfortably. So then they look at a surgical intervention. In my courses that I run, when people come for DALK, I always tell them that everybody comes with think I want to do the big bubble. I tell them, when you start off, don't do big bubble. All your cases only do a manual near Descemet's. Why? Because first of all, you will complete the surgery. Otherwise, what happens is you go to inject the big bubble, and you sometimes you get the bubble, but still while excising stroma, you perforate, then you convert to a PK. Whereas if you straight away go and do a near Descemet's manual dissection, what I've seen them in the wet lab do, the wet lab practice, most of them can do that very easily. So in the sense that you will have successful DALK surgery done. And once you do that, your confidence level builds up. So I think, one, if you do at least 10 or 15 manual DALK and you're able to complete that, you get the practice to feel. And then when you do a big bubble, but you don't get the bubble, you can fall back, but you're already good at doing a manual DALK. So you give the patient a good outcome. Or even if you perforate, the steps of manual DALK you already know. So, you can easily navigate through that.
Thank you so much, sir. In fact, I think most of the cornea surgeons, they also follow the same thing. If the patient is happy with contact lens, don't touch the cornea.
Correct.
And Dr. Prabhat and Dr. Twinkle, any points from your side?
Sir, wonderful, lecture as always. Every time you are there in Nagpur or elsewhere, I make it a point to sit in the hall so that I'll gain some more new points. Sir, I wanted to ask you, you do your groove and peel a little bit differently from what it has been described. Um, so you tend to kind of dissect across, as I understood it. You may correct me if I'm wrong, but you tend to kind of dissect across the apex and then peel it. But traditionally, it has been described.
No. I think if you see, what you saw dissect across,
Right.
the first layer was debulking.
Okay, yes, sir. Yes,
So
sir.
instead of working with the full cornea, sometimes what happens is the whole cornea is very bulky, difficult to hold with the forceps.
Yes, sir.
But if you take off 40-50% of the anterior lamellae,
Okay.
then the remaining posterior part, visualization of what is happening behind is also easier. And you can hold, the residual stroma does not become bulky. The
Okay.
principle is the same as what were described by Enrique Malbran. Malbran used to use a 10.5 millimeter trephine and do a partial deep trepanation in the periphery, then make that peripheral plane, and then he used to just peel off across the cornea.
Yes, sir.
All other techniques, whether it's the grip and rape, groove and peel, whatever has been described, all are modifications of the same principle described by Malbran.
Yes,
So
sir.
here also the idea is that you do your trephination at the edge of the trephination, create a deep plane which is very close to the racemes, and then you can extend that pocket on either side, whether you use a scissor or like a blunt dissector, or and once you have done that, then you hold, at least you have done it for 270 degrees, if not 360. Then you start peeling off and the apex. So as you peel off, you come to the apex and cross over. What you are referring to is maybe that you dissect from all sides and come to the apex at the end.
So yes, exactly, sir. So kind of dissect and just do that. I mean,
Sure, sure. It can be done. If your apex, like a post hydrops, where the apex is the weakest point, then you want to come to the weakest point at the end. Then you may be, but think of it when you, as a surgeon, when you're sitting superiorly and you're operating, to dissect from the top to the bottom is easier for you because you can see. But if you come from 6 o'clock superiorly, your hand also
much
moves to the
harder.
other side, but
Yes.
your visualization is not there. And if you do it without proper visualization and control, the chance of perforating will be more. So for me, I think visualization, sometimes I change my sitting position also. If I'm seated at 12 o'clock and I'm operating, for certain steps, I go to the temporal side, because then what happens is I'm able to see better and my angulation changes. I often, in those kind of cases, I use a combination technique of both blunt and sharp dissection. That means in the periphery where the stroma is normal, I will go with my blunt instrument. But when I come to the very like apex where there's a previous perforation or something, to avoid applying too much of pressure, I may use a little bit of sharp dissection, either by breaking those fibers with a Vannas or use a crescent just to break the fibers on the upper side, not at the bottom.
Yeah. Just cut the bridging fibers, but more towards what you
Correct.
already caught and held up.
Yes. So basically, if you are holding a tissue, your
Hmm.
fiber has two ends,
Yes,
not
sir.
at the base, but at the top where it is.
At
So
the
you
top.
cut there.
Yes,
Yeah.
sir.
Yeah.
Yes, sir. And sir, building on what you said about visual potential, I think that's particularly important in children to first do the contact lens trial, because we really don't know when, in young children, when the keratoconus may have started in advanced cases. So
Correct.
the contact lens trial will really help us prognosticate what we would like to do going forward. Sir, I also saw some of your cases, you have some amount of posterior scarring, and the scarring tended to kind of fade a little bit over time. In some of your cases, I've seen that. So that
Yeah.
has been
Yeah.
my experience
So
with one patient also.
it can happen because of corneal remodeling.
Yes,
But
sir.
like I
Yes.
say that if I see a patient with high drops, like recently I had a 10-year-old child and he had high drops in December with advanced keratoconus, and he presented to me. Now he has a healed high drop scar and advanced keratoconus. So I gave both the options of PKP versus doing a manual DAL. So in a child 10 years, if you do a PK,
Mm.
he has to use steroids for longer period of time. He still will have the suture-related astigmatism. So, and the parents will have to monitor the child more frequent visits. I gave the option that we will try and do a DALK because the scar was not entirely obscuring the pupil. So I said, no harm, you basically remove 85-90% of the stroma. We did the surgery. And day one, the patient was, I just said, okay, take a pinhole and read. He was reading about 618, 612. And that's good because, nothing like retaining your own endothelium. And in the future, if he does get, does the required surgery, what you can do with the femtosecond laser is you don't need to do anything to the previous graft. You can use the femtosecond laser just like you make your capsular axis cut. You can make a circular posterior corneal cut.
Mhm.
You can prime the laser, and just like so, you give the limits in the posterior where the stroma is, and it'll cut out a disc. And then you can go with a reverse Sinskey and peel off the original residual posterior stroma.
Yes, sir.
Take it out, and you can prepare a ultra thin DSEC and put it into that space. So you can address that. All will be a closed chamber surgery. At no point you're opening the chamber. So it's good for its crystalline lens, less chance of inducing secondary glaucoma because you're not manipulating the chamber. So I think there are many ways of doing surgery, and sometimes counseling the parents and explaining to them the advantages. And we tell them by doing a DULC, you're not losing anything. If it doesn't have a satisfactory outcome, we have ways to fix it. It's not like if you do this, you cannot do the other one. But the advantage of using minimal steroids, avoiding secondary glaucoma and cataract, I think that's quite useful in a young patient.
Absolutely, absolutely. One of the differences that I've noted with suturing in manual DALC is because, technically manual DALC does not need a paracentesis. Is that the globe is a little bit harder than PK. So there may be a tendency when you're starting off is to pull the sutures quite hard to just make it oppose in the periphery. So I always recommend that for a manual DALC, just make the paracentesis just to soften the globe a little bit. So that suturing becomes a little bit
So
easier.
what I like to do when I'm suturing is I make a paracentesis and then I fill the chamber with air.
Okay.
I put a large air bubble.
Yes, sir.
And the logic behind it is when you do a paracentesis and you release aqueous, what happens? The eye becomes soft.
Yes, sir.
The eye becomes soft, the cornea tends to collapse.
Yes, sir.
Whereas when you put an air bubble, the air bubble will
Maintain
make
the
the eye
contour.
soft, but it will
Yeah.
maintain the contour of the cornea.
Yes, sir.
So it will not allow the cornea to become excessively flat. So when you put in your donor tissue, you can titrate that and you can put your sutures, maintaining the curvature.
Okay. Wow. Thank you, sir. Thank you.
And
Yes.
at the end of surgery, just replace the air with fluid. So it's kind of that's what my logic is. And the paracentesis is important also because if in case while doing a manual DALC, if you do encounter a perforation, it's easier to make a paracentesis before than making a paracentesis after the perforation, because in a soft eye, going and making a paracentesis is difficult. But if you make a paracentesis before you start your deeper dissection, what happens is, like you said, you can soften the eye when you're suturing. If let's say you had a perforation, you can immediately put in an air bubble without at that point of time panicking. And in a soft eye, you go in with a knife. If the knife is not very sharp, or you apply too much of pressure, you go in, you hit the iris, you might hit the lens as well. So it makes it, and making a paracentesis is also a little difficult in a soft eye.
Yes, sir. Thank you, sir. Thank you.
Thank you, Prabhat. Twinkle, you have any point to make?
Yeah, sir, thank you so much for the wonderful lecture. And I make it a point to see your surgery every time before I start my own DAL, just as a revision. So one thing I would like to ask is there any difference in the initial depth of trepanation that you make when you are doing a planned manual DALC vis-a-vis big bubble DALC?
No, the idea is that we go about at least 75-80% of the thickness. So if the peripheral thickness is more than 500 microns, then with the suction trephine, you can go about 6 quarter turns with ease when you're beginning. For me, I go 7 quarter turns. So that's about 420 microns of trephination. So that gives you a good starting point. The only caveat I would like to give for manual DALC is that in a manual DALC, you leave behind a residual bed ranging from 150 microns. So instead of putting a full thickness cornea, if you take a donor cornea, if you have access to a microkeratome, like the DSEC cap, what you get, I use a 400 micron head and I cut off an anterior cap and I punch out. So my donor is 400 microns. And I find that when I put this and I suture, I get excellent apposition. My graft versus junction is flush. And post-op also, the visual outcomes are better. But if you take a full thickness donor and you try to fix it there, what happens is, first of all, the edges don't match. You may be able to put tight sutures and make the edges coapt, but later on when you do suture removal, on topography, you'll see a red ring all around the graft versus junction. That's where the edge, so that kind of induces aberrations. And so for manual DALC, don't put full thickness. If you don't have a microkeratome, put your tissue on the artificial chamber, just like you prepare a manual DSEC graft. You make a peripheral groove of 400, 450 microns, use a lamellar dissector, dissect across the cornea, take this graft, punch it out, and place it, and you will find that your patient's refractive outcomes will be much better.
Thank you, sir. So I'll go through the audience question quickly. And there was a question from Dr. Jayashree Roy. I think what she wants to know is once you are successfully dissected, whether you will go for a preserved cornea or a fresh cornea for DALK.
I think she meant preserved cornea is what, like a glycerin preserved cornea?
I think she's asking that.
Well, I think in COVID time, there were some papers. I think IGO, there was a paper published on using glycerin preserved cornea for DALK. You can use it, but I think there will be a haze on the cornea. That is number one. Second thing is re-epithelialization takes a longer in these eyes because there are no nerve endings in the cornea, and no keratocytes. So somehow the surface will take longer to stabilize, and the graft to become clear also, it will take longer. Glycerin preserved corneas are a little leathery. So while suturing also, you may find that it's a little bit more difficult to suture. But I would put it that way that if you want, you can, like, let's say iBank tells you I have a therapeutic grade cornea where the stroma is clear. You can keep that, and if you have a good cornea, you can use it for another case of PKP. For me, if I'm doing a DMEC and a DALK, I use the Decimus for DMEC and the remaining stroma I use for a DALK. So I think don't peel off your Decimus before you do your DALK. Go with the surgery and see, ultimately, I don't think you need to, discriminate. The patient is coming for a good surgery. At times, if you don't have, you have whatever cornea you have to use. If you want, you can think of having a fresh bottle of cortisol, and you can peel off the decimets and store the decimets in that if you feel that you want to use it for a DMEC or something.
I think Dr. Jayashree, I think you got your answer. As far as possible, use a non-optical grade fresh cornea. Glycerin preserve, of course, if you have nothing, no alternative, then you can use that. Then there are a few more questions. That when would you like to start removing the sutures after DALK?
Well, suture removal, you would want to keep it as long as possible. So basically at 3 months, if I've done interrupted sutures, at 3 months, I can look at, and based on the refraction that I have on the steep axis, maybe I can remove 1 or 2 sutures. But what I also do is I do resuturing, in the sense that if I find I have to remove few sutures to, reduce the astigmatism, I take the patient back to the LASIK room under topical, I put sutures again of appropriate tension. What I find is in the early post-op, if you remove sutures, you create microdehiscence on your graft-verse junction. So at that point of time, that cornea may look good in terms of the refractive outcome, but so the healing is different between the area that you have removed sutures versus the area where the sutures are still in place. So later on, when those sutures are removed, again, you get induced astigmatism. So I find that if I can go back and replace sutures, I kind of maintain the healing the same in all areas. But if it's just an occasional suture out of 16, it doesn't matter.
I think what she meant is when would you plan removing all the sutures, probably?
I try to keep them as long as possible. If the refraction is good, I just tell them, just keep coming for regular follow-up. And whenever they break or become loose, we remove them. But if they are going back to an area where they are not likely to be coming back for a follow-up, or they are going abroad, then I think at least 1 year, beyond 1 year, you can think about removing the sutures.
It's a very practical point which sir said. Always do a refraction. If your patient vision is good, happy, don't try to remove the sutures. The vision may change. And yes, any pre-op medication for DALK you prefer?
So not necessarily pre-op medication for DALK. We know that ectatic disorders are associated with allergic eye disease. If somebody has an active surface, then better to treat that first. Otherwise, like active surface, when I meant is either an active allergic eye disease, or if he has meibomian gland dysfunction. So all these need to be treated before the surgery. Otherwise, because of this, what will happen is post-op, you will get sterile suture infiltrate, sutures will become loose, you will have problems, with the surface healing. So it's better to treat all this before rather than do post-op.
There are 3 questions related to the air injection. First is whether you prefer 30 gauge or 26 gauge needle to inject air.
Well, I think there is no comparative study that looks at 27 versus 30. But the volume of air that would come out with a 30 gauge would be definitely be less compared to a 27 or 26 gauge. But 30 gauge makes it easier because it's more narrow. You can insert it easily. So I would say that stick to a cannula, you know.
Yes. And next
Take
question related to
but
that
yes,
only.
in my hands, yeah, whether I take a 30 or a 27 or a 26, I can still make the bubble because of years of experience. I know I have control over where my tip is going. But remember, the more the finer the needle, the easier to perforate posteriorly.
And whether you will like to inject it fast or slow when you're injecting the air. Is it a
I
fast?
use a 5 cc syringe with about at least 3.5 cc of air. And when you inject air, if you are deep enough, and so if your track is not, the other problem that I find is when people make a track and they go into the track, they keep moving the cannula so much that the track becomes wider. And then when you inject air, all that air leaks back, and then you find there is hardly any resistance. Usually, if your tip is very snug in the stroma, and when you try to inject air, you will find that there is a considerable amount of resistance that you feel. So you need to give a nice firm pressure. At the same time, watch the tip of your cannula, what's happening there. So inject with force, see that emphysema starting, and then you will feel a sudden ease of resistance and you will see the bubble appearing. At that point of time, immediately stop. Because once your bubble is formed, a subsequent air injection will go in the same plane. So it's not like if you stop, you cannot go back and enlarge the bubble. So I get that once I see my bubble, I stop, I do the paracentesis to soften the eye. Then you go back into the same this thing and inject air, you will find that bubble will enlarge. Otherwise, without doing the paracentesis, if you try to inject air, your resistance will keep increasing as the bubble, and the bubble will stop going beyond a certain point. So you will have a partial, for 8 millimeter trephine, you may have only a 6 millimeter bubble that doesn't go beyond. And if you try to forcibly do that, it breaks. What about doing a paracentesis before you inject air? Why not make the eye soft before you inject air? That's again, sometimes people ask, and some people do that. They make the eye soft. Well, if you make the eye soft, the counter resistance minimizes. So the chances of bubble will increase. Definitely you will get, like in the wet lab when we do people on donor corneas, we always ask them to soften the eye before they inject air. Because otherwise the donor corneas are soft, they all get emphysema. But if they make the eye soft and inject air, they can get the big bubble. That's good, but so think about it. What does the aqueous do? Aqueous is like a shock absorber, It provides that counter resistance. So when you inject air, so when the bubble starts, it kind of stops the bubble from expanding. But if you take out that component, then what happens is you inject air forcibly, you will get the bubble, the rate of bubble formation with the rate of expansion will be very rapid. You will inject air and you will find the bubble will immediately go up to the 8.5. And if you don't control your injection, sometimes that will go and it will burst. So that means you lose control over the rate of expansion of the bubble. The second thing is when you do the paracentesis, what are you doing? You're creating a break in the decimus on the inner lip, the entry point. So if you inject air and instead of a type 1, if you get a type 2 bubble, which is where the separation is between the decimus and the predecimus layer, and that bubble reaches the point of paracentesis, and you already have a break in the decimus, the air will cause that break in decimus to enlarge, or it might rip. You might find the air coming into the anterior chamber. So one way is that you can avoid that complication from happening.
Very, very important practical point. I hope people remember that. And I'll conclude with the last question. And yes, I think probably the visco that you used before burping the air. So what type of viscoelastic you prefer, and can it increase the risk of double interchamber post-operatively?
We use cohesive viscoelastic because that's easier to remove. Viscoelastic in a air injection big bubble, people use it after doing the brave slash when they deflate the bubble. Then they inject visco again so that now they can put the season and excise the stroma. That's good if you have a very tiny opening, you don't know where the opening is, you fill the. But what happens is once you put viscoelastic, your entire surgical field becomes very gooey, You can't really see where the posterior layer is when you're putting your scissors, you don't. So that's why I feel that once you make the 4-quadrant cut, wash out all the viscoelastic. Use a 10 cc syringe with a bigger cannula. Don't use a very fine cannula because you don't want too much of pressure. Gently irrigate and make sure that all that excess visco is gone. dry the surface with a Merocel sponge, and then you can identify the areas where the adhesions are still there, break them, and then remove the stroma. So I think it's very important. If you leave behind residual visco, definitely you will get a non-resolving double anterior chamber, which way even when you put air or C3F, it doesn't resolve because there is a physical presence of viscoelastic. If that happens, then you have to go back, maybe cut 1 or 2 sutures, and then you have to kind of, burp out the viscoelastic after doing a complete air fill.
Thank you, sir. I think there are 6, 7 more questions, but I'll share it with you. And I think because
Sure, no problem.
saying
We
that
can
time.
share in the group, we can tell them.
So, Sharik, you compile all these webcast question and share it with me. Okay. And I think it's time now that we should conclude this wonderful session. Thank you so much, Phogla sir. Your all practical points,
It's always a pleasure to share my work.
Even you hear it again and again, then you want to hear it again. So we'll keep on inviting you for DALK again
No
for
problem.
those conferences.
Mm.
And thank you to the panel, Dr. Sasank, Dr. Mugundan, Twinkle, and Prabhat. You really carry forward the discussion so well. And with this, we'll conclude here. And sir, if you come and join us at our annual DOS, we'll felicitate you for this webinar. I'll shortly may send you an email inviting for that. Thank you so much and good night all.
Okay, thank you.
Thank you,
Good night.
sir. Thank you, everybody.
Bye.
Good night. Good night.